We were recently treating and taking care of a patient with some upper extremity numbness, tingling, and pain. We had treated a disc herniation in her neck, and I thought, gosh, we got the disc herniation out. It was pretty big, right on the nerve, and I expected her to feel a lot better. But she came back to clinic and said, well, I'm a little bit better, but I still have this upper extremity numbness and weakness, and it's actually getting worse. So we did a deeper dive into her problem and concluded that she also had thoracic outlet syndrome. And I wanted to take a minute to talk about thoracic outlet syndrome, how it's diagnosed and why it can be a challenging diagnosis, and how it is most effectively managed and treated. The brain connects to the spinal cord, and then off of the spinal cord, the nerves leave the spine, and they travel past the discs and past the spine and the neural foramen, and could be affected along that course. And disc herniations and bone spurs commonly affect the nerves. However, they have to continue on down the arm or down the leg and could be affected anywhere along their course. The nerves coming off the cervical spinal cord leave the spine, and then they mix and mingle and become what we call the brachial plexus. The brachial plexus travels past the shoulder and into the arm and splits off into nerves that we may know: the ulnar nerve, the median nerve, the radial nerve, musculocutaneous nerve. As the brachial plexus passes the shoulder, it goes through an area that is called the thoracic outlet. It passes between two muscles, the anterior and middle scalene. It goes under the clavicle and over the first rib. Accompanied with the brachial plexus is the artery that goes to the upper extremity. If there is pressure on the brachial plexus or the artery as it passes through that thoracic outlet, a patient could have numbness, tingling, or weakness in their arm. Patients that are at risk for thoracic outlet syndrome would be especially women. It's more common in women, potentially because of increased laxity of the ligaments and also the breast tissue pulling down on the shoulder. It's more common when there is repetitive overhead use of the arm, such as with a swimmer or a tennis player. Thoracic outlet syndrome actually may represent an overuse injury. How is it diagnosed? First, I think we need to have a high index of suspicion for thoracic outlet syndrome. It's not easily identified on imaging, and the symptoms can be variable. Symptoms that are worse with the arm extended is a good clue. On physical exam, patients that are tender over the brachial plexus and a couple of other physical exam findings can give us some additional information. Imaging studies are somewhat helpful. We can do some specific imaging studies of the thoracic outlet, which are not as easy to interpret, at least in my experience, as images are, say, of the cervical spine itself. A lot of the imaging studies that are done are to rule out other causes. A nerve conduction study could show evidence for thoracic outlet syndrome, but patients with thoracic outlet pain and problems could have a normal nerve conduction study because of the positional nature of the problem. How is thoracic outlet syndrome managed? The vast majority of patients improve with physical therapy, about 90% or so. So patients with a suspected diagnosis of thoracic outlet syndrome should work closely with a physical therapist, and maybe for a few months. Consideration for overuse injuries and scaling back or making modifications to overhead activities may be appropriate. Surgery is occasionally done for thoracic outlet syndrome in patients for whom the diagnosis has been made and non-surgical management is not helpful. One test that could be helpful to both secure the diagnosis and identify patients for surgery is to inject botulism toxin into the muscles near those nerves to help them relax and see if the symptoms improve. In conclusion, thoracic outlet syndrome is a difficult diagnosis to conclusively make. It requires a careful history, physical exam, and the appropriate diagnostic tests. Mostly, I think it takes a high index of suspicion in patients that have upper extremity numbness, tingling, and pain for whom we don't have an obvious source.